introduce Kern Singh, who is the most prolific author in JOEI history. We're very pleased with that. Kern, why don't you introduce yourself to the whole audience? And besides being a Denver Broncos fan, it seems.
Yeah, no, I literally just got home from the OR and got showered up, and I'm just relaxing. So, first of all, thank you for this opportunity. For those who don't know me, I'm at Rush in Chicago. I'm a professor there. I've been now, this is my 18th year in clinical practice.
Wow.
I was a classically trained orthopedics surgeon. I did my residency here in Rush, and then I did my fellowship, my spine surgery fellowship at Emory University in Atlanta. I was a med student at Jefferson. I think I was the first research student for Alex Vaquero, and I saw kind of what he did. He gave me an opportunity, first or second, I can't remember, but gave me an opportunity. And I always said I give opportunities to other medical students. And over the years, has been fortunate enough to create a prolific and hardworking research team. It's been 18 years of doing it. I think I have 8 to 10 students per year.
Wow.
And you can say that's 150, 200 students over the course of my career, and maybe only 3 or 4 bad apples, and everyone else has just been phenomenal. So my passions have always been research to make myself better selfishly. So everything I do, I kind of look back and see how I can become better as a surgeon. And over the years, I transitioned from inpatient work to outpatient spine surgery, which is kind of the impetus of this article as well.
Yeah, that's great. I mean, I just want to give you a little historical significance. When I was Dick Rothman's fellow
Oh, wow.
in 1990 to 91. Okay, I was a fellow in joint replacement with him,
Bill Hozak.
Bob Booth,
Yeah.
and Bill Hozak's first year.
Yeah.
He was a junior attending that year.
Yeah.
And my chief resident was Alex Vaccaro.
Oh, that's crazy.
And my PGY4 was Todd Albert.
Yeah.
And my other chief resident was Mike Siccardi, who was a sports medicine.
Yeah, absolutely.
It was quite a class.
Absolutely.
Quite a class corralling them. So let me ask you a couple of questions about the article. First of all, explain to us the role of laminoplasty versus what I would call a classic ACDF. First of all, because that you made a big point of that in the article in the beginning. How often do you do that versus an ACDF? And are there classic indications, or is it just surgeon philosophy?
Yeah, so at this point in my practice now, I very rarely, if ever, do an ACDF for degenerative pathology. It has to be deformity. So my bias has been now some type of motion preserving procedure, whether that be cervical disc arthroplasty or laminoplasty. And laminoplasty to me is a procedure in which I have multi-level disease and myelopathy and spinal cord compression. I almost never ever do cervical fusions in the neck anymore. It's very rare, unless they are kyphotic or it's iatrogenic, some deformity, infection. But for degenerative conditions, whether it be 1 to 3 level cervical disc replacement, if it's more than that, then laminoplasty. But I find I struggle to recommend a procedure that I wouldn't do on myself.
Right. Yeah, now I'm thinking as a chair of the department, I need to speak to my spine surgeons who are in ACDF, are on an ACDF run nonstop.
Well, so Ira, it's one of the interesting things. A cervical disc replacement and a cervical laminoplasty are harder technically to perform, I believe, than their ACDF and posterior cervical fusion counterparts. And the biggest challenge is they are reimbursed, 30, 40% less than the fusion. So, you can say what you want with that, but something that's more technically demanding takes, a little bit more nuance and paid less is never a motivating factor for people to change.
Yeah, that's true. What about the recovery of a same patient with both procedures? I don't care where you do it just yet, ASC or a hospital, 23-hour stay or outpatient, recovery of a laminoplasty ACDF.
So, an anterior approach I actually say an anterior approach is probably the most minimally invasive thing we do in spine surgery. There's no muscle cutting, there's no bleeding. So the recovery is immediate. A laminoplasty no matter how gentle you are, no matter what you do, you ultimately have some muscular disruption. So
Right.
it definitely is a challenge. In general, though, what I've learned over the course of my career is that, I don't treat a laminoplasty exposure like a posterior cervical laminectomy and fusion exposure, where I just kind of hack up all the muscle, put the screws in, I'm out, and close up what looks like dog meat at the end. I'm much more selective, and I'm much more careful how I do my exposures. I'm much more careful about how I control bleeding, how I do an infiltrative pain block.
Right.
And so the recovery, I tell patients typically for a laminoplasty, depending upon how neurologically debilitated or not they are, but they're walking the same day. And
Right.
then I tell them off work for no more than 3 to 5 days. So, if they're going back to some type of light duty or sedentary duty, then I return them back within 3 to 5 days.
Wow. So that's amazing. I mean, I am now approximately 65, having turned that a few weeks ago. And
How is it approximately then? Isn't that you are 65?
Yeah, it's kind of a good lie, pretty much. It's called denial.
Yeah.
More than a river in Egypt. It's
Yeah.
I
I'm 46. I'm going 47. And I feel like years are accelerating on me.
Yeah, no, they stop at 65. I'm not counting anymore, but of course, you hear this all the time. Remember the extended stays and so when did you start making the move to the standardization that you talked about in the article, to the standardization to bring this to an outpatient procedure comfortably for you?
So I had a philosophical shift in my practice. I think like I said, I was classically trained and came out first couple of years of my practice doing open surgery, and I just felt kind of dissatisfied. So I transitioned to minimally invasive, and then you can start saying standardization around 15 years ago.
Wow. Okay.
Transition, and I was self-taught. So I went around meetings and asked people, and most people actually lied to me about their complication rates and whether they were doing the procedure or not. And so I felt a little bit kind of disheartened. Anyway, I went to a critical point in my life where I actually questioned whether it was the right thing to do. I had high complication rate. I had, errant placement of screws, inadequate decompression, different things like that. And then I blew through that learning curve. So, I give a talk when I kind of give these visiting professorships and grand rounds, which will probably touch your heart. But I talk about it. I think the title is something of spine surgery, everything I wish I knew I should have learned from a joint surgeon. And the essence of the talk is, I bet you if you watch the joint surgeons here at Rush or joint surgeons at your institution and your department across the country, across the world, 95% of what people do is exactly the same, like very similar. You have nuances, you change, you may be better at doing it, but the procedural steps are the same. You can walk into an operating room at Rush across the hallway, and the same diagnosis and whatever it may be, same procedure is done completely different.
Wow.
Meaning the setup, the trays, everything. And I said to myself, that doesn't make any sense. So I watched very efficient surgeons. I was fortunate in my career to watch Alex Vaquero. I was fortunate in my career to watch, as a med student, I should say, Bob Booth.
Yeah, of course.
Fortunate to watch Dick Rothman. I was very fortunate to watch actually Rich Berger here. And I learned efficiencies. And I just kind of watched how they streamlined the process. And it always made me wonder, why the hell are we doing that in spine surgery? I mean, it's crazy. And so I started paring down the instrument trays. I started paring down the procedural steps, created PowerPoint slides for everybody. I'd post them on the walls. So my staff knew exactly 5 minutes into the procedure where we would be, what instrumentation, et cetera. But I learned it from joint surgeons, to be honest.
Wow, it's really incredible. I mean, there is a great Harvard Business Review article, which I may send you, called "Surgery at Rittenhouse Hospital." Pennsylvania Hospital didn't allow the use of the word Pennsylvania Hospital, so they called it Rittenhouse in the article. But it was Bob Booth's journey of standardization, and how the Harvard Business Review, brought it up as a sort of almost like a Toyota way of really looking at your operating room. And
I did. So I don't think people even I don't even think Bob Booth would even remember me, but I've always believed in the mantra, which is, if you're the smartest person in the room, you're in the wrong room.
yeah,
So when I got done with my training, I actually went back to Jefferson. I went back and I saw Bob Booth at Rittenhouse Hospital.
yeah,
I spent a week just under the radar watching surgeons and kind of figuring out what they did best and kind of applying that. And that kind of helped my transition into a more, I guess, structured spine surgery. And now anyone who scrubs with me, whether it be my fellows or whether it be my residents or medical students, they just know it's just a very reproducible process for all the procedures that I do.
Yeah, I think that's great. I think as a joint surgeon, obviously, I more than appreciate that. I mean, at our hospital, we moved 6 trays for joints to 1 tray from the hospital, 2 trays from the company.
Yeah, exactly.
It's a game changer.
Yes, exactly.
We got our length of stay, even at a safety net hospital, down to 1.9 days.
Yeah, see, that's phenomenal. So, I see one of my fellows was with me today. He's his first or second day with me. And so today I was in the ASC, so he can call BS if I'm lying. We made an incision today at 8:30 in the morning. I went to the gym in the morning. I worked out. 8:30, we did, first case was a decompression, tubular decompression. Second case was a cervical disc replacement, C3-4.
Wow.
Third case was a 2-level decompression. Fourth case was a front back XLIF lateral PSF. And the fifth case was an MIS TLIF. And I was in my clinic at 1 p.m. So we started at 8:30. I did all those 5 cases. I was in my office at 1 p.m. And then we saw 40 patients and I was done at 5 o'clock. And that is reproducibility.
Yeah, that is so much the story of what you're doing. The work, how much work for you goes into, now that you got it done, but I'm talking about in monitoring the post-op. How do you monitor post-op? Do you have a nurse navigator? What do you do in the post-op period?
Sure. Well, it's an interesting question. I think post-operative management oftentimes is best handled by preoperative education.
Okay, got it.
So, I also learned that from the joint surgeons. Joint surgeons do a standardized joint teaching class. So they teach what to expect, what to look out for. And I've standardized that teaching. So my physician assistants are essential in that. So we do a very much like a joint surgery preoperative education course, so on our patients. And then post-operatively, we contact the patients the night of surgery, so after they're discharged, because Illinois does not have a 23-hour stay. So when we discharge, they have to be discharged, within the 6-hour, 8-hour window.
Absolutely right, yeah.
So we call them the night of surgery, and then we call them the first thing in the morning. And then the third thing is, and people always say people call me crazy in a spine meeting when I told them this. I give every single patient my cell phone number and my email address. And I can tell you, in the 15 years, now 12 years of doing a lot of ASC work, no one has ever abused it. And it's probably saved patients from going to the emergency room, urgent care clinic, et cetera.
Absolutely.
Over and over again. And in Illinois, what people don't realize is if my patient bounces back to the emergency room or to a hospital within the 72-hour window post-operatively, that's a negative citation and you can lose your certificate of need. So we can lose our licensure for our, say, ASC.
Wow.
So
I mean,
we
that's,
have to be very like on top of it. And my PAs are always available, and contacting the patient. Reassurance a lot of times is the main thing.
it's actually, I mean, we share the same philosophy. When I was in private practice before I came to the hospital, my cell phone was on my business card. And
Yeah.
it said direct to the doctor, was a direct to doctor. And I used to pick up the phone and say, hi, it's Dr. Kirschman. I said, I'd like to speak to Dr. Kirschman. I said, this is him. I said, no, come on. I said, well, what do you think direct to the doctor means?
Well,
And
Ira, you're dating yourself, because I'm a little bit older too, but not as old as wise as you. No one calls anymore and no one talks anymore. So they just text or whatever.
yeah,
So
that's true. They
most
call
patients will just text nowadays. I think talking and is probably a lost art at this point.
Yeah, it's true. That's true. As is cursive writing, also a lost art.
So,
But
so Kern, while
Yeah.
we're all discussing how old we are, say hi to Rich Berger. I was a PhD student, graduate resident at MIT when he was an undergrad there. So
Oh my God. Yeah.
say hi for me.
Of course I will, Greg. Of course.
yeah, that's great. So, what are your feelings? So, I have this philosophy about reimbursement in the decreased length of stay era. Beforehand, we're saving insurance companies all this incredible money by doing it in the ASC. But we're not getting paid, you're not getting paid for the remote therapeutic monitoring. And I use that term specifically because it's a new term. But the post-op monitoring of that the staff puts in is a cost. And the cost savings that we have given the insurance companies and Medicare for saving them inpatient stays and keeping them out of the emergency room and out of urgent care. What are your feelings about, a shift in reimbursement for some of that post-operative care?
First, actually, this is the first time I've actually thought of it that way. I mean, that's actually interesting. I looked at the decreasing reimbursement. I just thought that I could increase the efficiencies and throughput, and that would be the resolution, not dealing with the race at the bottom. But you know what? How they calculate an RVU for our surgical procedures is kind of antiquated now that you mention it to me, because this shifting of an ASC procedure, the RVU should go up for the post-operative and preoperative care, because you're spending more time educating them and taking care of them on the back end.
Yeah.
So, you're 100% right. Actually, I never thought of it that way, but we are reducing the cost. That's the obvious, but the cost is reduced because of the man hours that we put in from the staff, from my team preoperatively and then postoperatively. And it's a non-reimbursed kind of model. And, at the end of the day, I made a mistake probably. When we transitioned to our ASC, this is now 11 years ago, I made the mistake because there was no outpatient spine codes. So we took comparable codes and we took small rates on it and reduced rates on it. And that was probably foolish. And we just tried to get the codes and then establish safety and efficacy and everything else. And ultimately what the insurers did was punish us and basically only allow us to negotiate based upon those prior negotiated rates. So the cost savings to them is irrelevant. The only upside, we don't have an out-of-network practice in Chicago. That's very hard to do in this market. But the only upside is for my outpatient procedure, which is 90% of my practice or 95% of my practice at this point, I have no pre-authorization requirements. So
that's bonus. Yeah.
Yeah. So everything gets authorized and they base it upon outcomes and costs and everything else over the last 10 years. So from that standpoint, it's been very good.
Wow, that's great. Yeah, no, it's something I've given a lot of thought to, in the sense, you think of Usain Bolt in 9 seconds.
By the way, I partied with him. I'll tell you that story in 2 weeks. 2 weeks ago, I partied with him. Or 3 weeks ago, sorry.
Really?
Yeah.
Let's hear that story first.
All right, I'll tell you the story because it was a good story. So I was down in Jamaica, and one of my wife's good friends is a plastic surgeon. She trained at Rush, and I knew her. Her husband is and they live in South Florida, but her husband is does business in Jamaica. He's from Jamaica. Anyway, he invited us down there, and it was the who's who of Jamaicans. So he was Usain Bolt, Shaggy, Q-Tip, a couple other people, and then
Wow.
us. And it was pretty good. We had a party on the beach in Ocho Rios. Everyone was having a good time. And apparently, it's part of the Jamaican culture. You take out a gun, and then like halfway through the party, you start shooting the gun up in the air. So all these bullets, stray bullets are going everywhere. That's when I cashed out. But I got to meet Usain Bolt. That's pretty cool.
That is very cool. I was thinking, so in 9 point whatever, 3 seconds, he does something remarkable, and people pay him for appearances and for endorsements for that 9.3 seconds. But in reality, he's getting paid for the 14 million hours of training beforehand and the 13 million hours of recovery afterwards. But we only see him for those 9.3 seconds.
That's correct.
And that's kind of how I look at the reimbursement now, that if you're going to pay us for episodic care in a bundled payment, don't just look at the RVU.
Yeah, no, I mean, you're 100% right. I mean, at the end of the day, the model, the current model does not incentivize quality of care and does not incentivize a reduction of cost, meaning that the physician is not proportionally rewarded for reducing hospital costs. And also, I mean, like, if you look at the recent CMS statements and the hospitals are pushing this, they're trying to remove outpatient codes now and put them back as inpatient only.
Yeah, I know.
And there's just, and they, who was I talking to? I was talking to somebody, and for most part, we have we're a private group in our institution, but chairman, as you know, chairman argue for the inpatient procedures to benefit the hospitals, their departments, and their coffers.
Of course.
There's no incentive to move this outpatient.
No. And well, I'm at a safety net hospital, so we don't really have the ASC, but I would agree with you that if I was in a position where there was private groups and ASCs, we'd be pushing for the inpatient CMIs and, increasing the CMI. It's absolutely remarkable to see. So where do you, I'm very interested in the research part. How do you set up this incredible spine research machine? I mean, because you got to tell people what to do. I mean, yes, you have 250 students, and they just don't walk in. And so, who organizes that? What's your structure of that research? Because you produce a huge amount of incredibly timely and thoughtful research, answering practical, serious questions. And that just doesn't happen by sitting in your backyard and penning a novella.
So I've asked myself, I go over this, and we have the new research students, and actually our current fellow, one of my current fellows was a former research student of mine years ago. So, when I first started, I used to interview everybody, and I was kind of hit or miss, but I would find distinct personalities that were successful. That means someone self-motivated, driven, maybe made a misstep in life, and it cost them the ability to go to medical school, or cost them the ability to get into orthopedics or whatever it may be.
Mm-hmm.
I took people who just seemed to be, honest and hardworking. Sounds cliched.
Yeah.
From that time period now, I actually let my team members, the students and everybody else involved, whether the pre-med students or the medical students or the ones that are going to go into orthopedic surgery, I let them interview and determine who goes next.
Wow.
And I have never intervened, and it has been phenomenal. And I think every year that I've done this, that year tries to make the research fellowship year better than the last. And they take pride in ownership. And the one thing I always tell them, I have like 500 papers, publications, a couple hundred books, chapters, books, etc. I never take first author. Never, ever take first author. Maybe once in a blue moon or whatever it is. So I reward them. I also reward them with autonomy. And by that, I mean, they have to collaborate. They have to work as a team. And then I send them to every meeting. And I tell you, Ira, surgeons have been pissed at me for, having my medical students or my pre-med students present and they get upset with that. And I said, it's a part of the reward.
Of
And the
course.
last thing,
I mean, it's a rite of passage that the youngest person gives the presentation. Yeah.
yeah, you would think so, but I think there's a lot of jealousy that way. I
Yeah.
think at the end of the day, it's just rewarding them. And then the honest truth of it is, it takes a lot of time. Like I only meet with them for 30 minutes or so in the morning on a Monday. I try to catch up on life a little bit, but I teach them technical writing by simple things. They write a paper. I use track edits on Microsoft Word.
Yes.
But it's me. It's me, like Greg is doing, reading the articles, providing them focus. And then, 6 weeks to 8 weeks, or maybe a month or two in, they're humming like last year's class. And
Right.
as long as they are hardworking and they're team oriented, I have yet to find someone that hasn't done very well. They all do very well.
That's great. It's a great service you're doing to the community, and I mean the medical community. We run a summer pre-med fellowship for 8 weeks for rising juniors and seniors, and we do 8 a year. And we try to squeeze out some research in the 8 weeks. They don't spend the whole year with us,
Yeah, I actually find it interesting. Let me tell you something. It keeps me young because every once in a while I'll talk to them about life and mistakes and whatever. But I kind of find out what's cool on Netflix. I find out what's
Yes.
going on with younger people. Like I can say I'm somewhat connected again, So
Right. You don't find yourself using words that are now not trending.
yeah, no, I learned and the other thing I learned is I actually do surveys also. So when I was a kid, you probably, this is a little after you, but when I was a kid, all the cool kids, all the rich kids used to have their birthdays at McDonald's.
Okay.
That was like the thing. And then I pulled my last year's fellowship class or research class, and none of them had been to McDonald's.
Wow.
So just interesting things, how things change.
Yeah.
And then I was just talking about social, meeting girls, guys, whoever your flavor is, and talking about it and talking about the lost art of, conversation. Everything is
Yes.
now, there's apps for everything. It's just, I find it interesting. I come
Yeah,
home, I tell my wife how cool I am because I learn a couple things here and there, cool series on Netflix or whatever. It keeps me a little bit younger.
That's great. That's great stuff. I'm going to switch gears to clinical for a second. So a young surgeon starts his practice in your hospital, and he's not getting your surgical times, because I saw in the article how your times went down. What advice do you give a young surgeon to bring their surgical times down?
Yeah, it's a great point. So
In spine surgery specifically.
Yeah, no, there's people talk about a learning curve being just a singular hump and then you get over the hump. It's actually, I think it's bimodal. There's two humps. And I say that because I think the first hump is actually just getting to accomplish the procedure and then getting better at the procedure, but then learning how poorly you're doing the procedure.
Right.
Like, great, you're getting better, but you're not really that good. And so there's a second hump. I found that the surgeons that we've trained, fellowship-wise, that have moved on to be very successful in MIS and outpatient spine surgery, et cetera, have been ones that have become good open surgeons first. And I say this, and most of the young guys don't listen to me, and they go out guns a-blazing, and then they have complications, and the hospital looks at them, and their competitive groups look at them and what's going on. But those that have that mastered the anatomy and everything else early,
Yes.
they're more willing to adopt new technology. And then the second factor I found to overcome that learning curve and to increase your efficiency is having partners, seasoned partners, who are able to provide insight and to, whether maybe scrubbing in or just to review the cases. I think having somebody around, whether that is a safety net or a crutch, I think that rapidly improves the young trainee or young surgeon's efficacy as well as their efficiency in the operating room.
I think you're right. I think, when I was fortunate for about 4 or 5 years to be an associate with Chit Ranawat, which was, just having him around to run a case by, the I'd show him a case I've never seen, and he'd say, "Oh, I've seen about 1,400 of these," or or something. I'm like,
Yeah.
great. So now when he tells me go left, go right, I know I'm doing that,
Yeah, no.
because of the experience.
I think young surgeons underestimate the value. If you have a senior partner who's willing to teach and to show you how they do things in the operating, you may take the good, a little bit of here and there from them, but it
Yes.
just exponentially improves your operative ability. Like just quickly puts you at a whole different level.
Are there any spine procedures no way you would do in an ASC?
The only ones that come to the top of my head, and they're not procedures, but conditions, tumors
Okay.
and infections.
Okay.
But otherwise, no, I mean, I do up to 3-level cervical disc replacements, cervical laminoplasty. We're transitioning our A-lifts to, I just wrote a paper on, scoring paper on predictiveness of outpatient A-lifts. So transitioning those, 1, 2, and 3-level lumbar fusions.
Wow.
So at this point, degenerative pathology, no, unless they have a medical comorbidity, sleep
Right.
apnea, BMI, no. But procedurally, nothing degenerative with our ASC and our anesthesia and then our predictability prevents us from doing that.
So in your process, who does your risk assessment? Is it anesthesia, or do you have a dedicated internist who does the risk assessment? Because as we know, doing things in an ASC or 23 hours or outpatient from a hospital, you really got to have an honest assessment and not the anesthesia resident who saw them on a slow Tuesday in clinic.
Yeah. So, honestly, we do our own risk assessments. So I have a classification scoring system that we utilize for just pre-op. The number one risk factor is sleep apnea. Person has sleep apnea, they're not going to the ASC. That's too high risk. So
Right.
that's the first thing. And then the second thing is, these are simple screening factors that we use: sleep apnea and then BMI. So we have a BMI cutoff of 40.
Right.
So above 40, they're out, just because it's just imaging and everything else. It's just not worth the hassle.
Yeah.
And then, so those two are just black and white, very easy. The third is the cardiac. And cardiac is interesting. So I have one center that I go to, which I was here today, and it is the best anesthesiologist I've ever worked with, and he's just phenomenal. So if I have a complicated case, then I typically have him review it, and I have one other attending anesthesiologist, and she's phenomenal. She actually does peds, but she does spine for me. She's phenomenal. So I have those two people review it, and this is simple cursory review of the chart, and they see them for me, and then if they give me the green light, then I'm good to go. But we use our own cursory kind of screening methodology.
Well, in the pre-op time period, how long is the wait for your surgery now for patients? Is it
To get my OR?
Yeah,
2 weeks.
2 weeks. That's great. And you're busy. I always said that's a sign of a great practice. You're fully booked, but it's 2 weeks to get in.
Yeah, I think it's because it's, I say, what is fully booked? Fully booked is artificial. I mean, I think this week we're on pace to do 18 to 20 cases,
Yeah.
So it's just a relative thing. I have partners who are booked out for 3 months, but they're only doing 4 cases a week. So it's all relative, right?
That's absolutely true.
So, for me, it's just the ASC is so highly efficient. Like I said, we did those 5 cases, about 4 hours of operative time, and I was able to see patients in clinic. My biggest thing right now is, if a patient needs to go to the hospital at Rush, then it's 4 to 6 weeks. I don't want to go there. I try to only do 1 case. I just do my case and then I leave. But I can't deal with that. And it's Rush, by the way, is a very efficient hospital.
Yeah, it's known to be. Yeah, sure.
Yeah, but it's just so grossly inefficient versus the ASC.
Yeah.
And plus, when you go to an ASC, what do I say? Everyone's goal is to facilitate, not
Yes.
to obstruct, but they are there to enable the procedure and enable the day to finish earlier.
Right. And no one's in a rush. Everyone's just
No,
not wasting time.
that's right. That is
You know,
100% right.
there is I had office hours today and I was doing a bunch of injections, and I was doing about 3 times the number of injections as 2 of my younger partners in the same time period. So the students I was with asked me, how do you get this done? Because you're not injecting faster, you're not running after the patients with the needles, and I will also inject hips without ultrasound because I know where the hip is. It's like I'm fine. And I drew on the page a picture of the local guy who is the hot dog vendor and how he sets up his hot dog stand in a certain way. And I said, look at my injection wall.
Those kosher hot dogs?
They're not kosher in the Bronx. No. They're the water dogs. Called the water dogs. And I said, watch him one day. He has no wasted motion, and everything's in the right place. And when you ask him for a hot dog, he gets it. Someone else does the bagging, and someone else does this, and he gets to the next person. You actually see the line move. And hospitals oftentimes just reinvent the wheel every month.
And what you said is actually very pertinent, which is I tell the fellows, efficiency is not generated by moving quickly. It is just eliminating redundant steps and missteps in the process. I will say the one thing about my practice, the transition to the ASC has been detrimental to fellowship training because we are so highly efficient. It is hard for them to get a mastery in the ASC setting. I don't have the risk tolerances of a misstep in the ASC.
So do you have fellows watch at least in the ASC or?
So I had a fellow today with me. I think it's an interesting concept. I've seen a generational shift over the last 10 years, which is fellows are, the great fellows that I've had that have really kind of taken the baton and moved forward, watched, took notes, really got stuff out of it. But most fellows seem disconnected at this point. And that's not necessarily just a generalization for everybody, but I think it's kind of, I think in fellowship, and maybe if you remember back, Ira, you put too much emphasis on actually trying to do the procedure versus understanding the steps and how to accomplish it. The physical act of doing it, anyone can do it. A monkey can do it, but can you put the whole thing together?
I always tell people that what I learned at the Rothman Institute in that fellowship, and I think that was only the 6th year of the joint fellowship when I was there. I learned how to be a surgeon. I didn't learn how to do the procedure. The procedure you knew you were going to learn.
Yeah.
But Dick and Bob and Hozek and Balderston and Bartolozzi were there, and they came up to me one day, and like the second week I was there, I heard you don't know all the steps yet. Big problem. And every day at the end of the day for a half hour, I'd speak to Dick Rothman about practice, he'd tell me stories about how the Institute became the Institute, or he'd quiz me and says, how do you think we could offer these nice things to the residents? Because we're efficient, because we don't mess around, because we don't have complications. Why don't we have complications? Because everyone's doing the same stuff.
That's right.
Everyone's doing it the same way. So we know what to expect.
Listen, I saw Dick Rothman at the end of his career, and I saw the efficiencies of the medical students and how phenomenal he was. And I was fortunate to see just people who were highly efficient and their complication profile is very low. And what people don't realize at the end of the day is, to make an efficient day like today, it's a lot of planning. I think about how I set up my operating rooms, how I set the schedule up. I think about how I'm going to do the procedures, the timing of the procedures. And those are all things that, you probably don't appreciate when you're in training. You realize it after the fact. Yes. And then you're like, oh my God. So I get a lot of fellows. I get a lot of awards now post fellowship teacher of the year award. So when people are going in practice, like, wait a minute, how did he set this up? How did he do this room? How did he flip this room? All those things that, in the fellowship year, I think they're so focused on, can I hold a kerosene and do a,
Right.
a laminectomy or whatever? When,
Okay.
yeah, you'll get that done. Don't worry about it. But learn from people who are doing it like an unbelievably right way. And I give the analogy, and I train them actually in steps. I train them how to hold a burr, how to use two hands, how to do these things versus the procedure. And the analogy I give is, you can learn a bad golf swing and you can maximize it, but your ceiling will be much lower than if you can deconstruct it and learn the proper golf swing. It may take you
Right.
longer and it may cause you some angst, but that will win in the end.
It's so
So let me-
true.
Can I push back on you guys?
Yeah, go ahead, Greg.
I actually love your last analogy, but ultimately, surgery is a psychomotor skill. You got to get out there and swing your golf club. You can't learn it watching, professional golfers, no matter how good they are. And so I agree with you completely, but there's a reason they're focused on the surgery, because they have to feel like they can do a surgery before they can become efficient at it. So I'm not saying you can't.
No, I agree with you, Greg, and maybe I misstated. What I say is, so like in this, if I have 8, 10 cases in a day or whatever it may be, I teach them, so they'll focus on one procedure will be doing the decompression, doing the hemilaminectomy, doing that.
Okay.
So what I'm saying is they may not be doing the whole entirety of the procedure, but they are learning each step
I
ultimately.
got it. Yep. No, I agree. Yeah, I did a sports fellowship, and I did it in Canada, which is actually a great place to do a fellowship. I did it with Pete Fowler and the group at London, Ontario, and they had a year wait list to do ACLs just because of the Canadian system and the backlist. But basically there was a fellow and a chief resident in every case, and we just sit down, they do the scope, you want a graft, what part do you want? And so we didn't do the whole procedure, but we did the parts, but we had lots of hands-on where, we were always involved in the case. And so, and then when I came out, I spent my first 7 years at a level 1 trauma center, out of a sports fellowship. But, there's nothing like struggling with a subtrope femur fracture by yourself to figure out the tricks. And yeah, it'd be nice if someone told you. And now I pass that along to my junior partners. And what you talked about before, I think some of the funnest time I have still is if I've got a junior partner and operate with them. That's great. It's fun to teach them the tricks that you've learned.
Yeah, I think it's interesting. Like I always go back and forth on our fellowship, and if I had to deconstruct or reconstruct our fellowship, I've always said this: what they should do is probably do the fellowship for 9 months, and the last 3 months spend with me, because learning spine anatomy is one challenge, and then learning it down an 18-millimeter tube is a whole different set of challenges. And so oftentimes they struggle with the anatomy first, and then you're looking through a tube and you can't figure it out. So it's just there's a transition in spine surgery learning it, and then there's a transition in kind of a tubular surgery. And then, so there's 2 different transitions they have to go through, unfortunately, in a year.
Well, I think you talked earlier about you learn to be an open surgeon and then you become minimally invasive. And I mean, I was the shoulder guy when I was at the level 1 trauma center. And I mean, everything was open. Actually, the toughest shoulder I ever did wasn't because it was a tough shoulder case. The patient was in a halo with a vest. Try and prep out a shoulder when someone's got a halo vest on. And but the residents don't see that. They don't see open shoulder anymore. They don't know how to approach fractures. They don't know how to do stabilization procedures that aren't through the scope. They don't know the anatomy because they only look at it through the scope. So I agree with you. We need more open procedures for the residents.
It's interesting. I used to go to a private hospital out in the suburbs here, and I was doing some cases there before, just because of overload of cases at Rush, and the nurses called me to help out a physician. There was a young neurosurgeon. He was 2 years into practice, and he couldn't put the pedicle screws down. And he couldn't put the pedicle screws down because, number one, he had trained, his entire fellowship was trained on navigation
Ah.
and robotics. and the O-arm went down and the robot went down, and he couldn't place it open and he couldn't place it fluoroscopically. And so I had to go over, help him out, put the screws down. But that's scary. I mean, that's crazy that you can't place a screw and you have to rely upon some navigation or robot. I mean, so that's kind of the reality that we're seeing in spine.
You know, it's very interesting. It always reminds me of this at business school. They always show this great video of people on a escalator, and then the escalator stops, and they start yelling for help. They say, help me, help me! We're stuck. We're stuck. The escalator has stuck. You know, and it's like Mitch Hedberg, the comedian, used to say, "There's no such thing as a broken escalator. It's just stairs." You know, but people.
I'm scared of escalators. When I was a kid, my shoelace got caught in it.
Oh,
my leg almost got amputated. So I'm like,
so you're all right.
I only wear Velcro and I don't go on escalators anymore. Just too scared.
So I'm going to open it up for some questions before we sum it up. If anyone has anything they want to talk about, how the research is done, I'll pause if somebody wants to just jump in. If not, I just have a few sum up questions. Okay, time for sum up questions. That's good. So take home lessons. Moving to the ASC is a long educational process, right?
Agreed.
Absolutely. And it has a pre-op and a post-op that require great thought. And it's not for the people who want to slash and just go home.
Agreed.
Yeah. And, what I got from the article was so much about the standardization and how you followed the process over time that validated what you were doing, because you looked at the operative time going up, you looked at the complications, you talked about the standardization. At some point in time, do you think any of that information you learned from the ASC can ever be transferred to hospitals, or are they kind of hopeless?
So I'm on the hospital leadership committee and I have a voice with the CEO of the health system. And I told them how to save, $5 to $10 million on these inefficiencies. And, unfortunately, it's just so bureaucratic and they're bean counters. They're not incentivized to make changes. But yeah, all this stuff could translate to highly efficient hospitals, but it's just it's a perverse concept. There's no profit sharing. There's no incentivization. There's no common goal. It's just, I don't know how you can move that needle in that direction.
It's a great point. I mean, people aren't even incentivized through thank yous, let alone incentivized through money.
I went to the hospital 5 years ago and I said, you want an 80% utilization of the operating rooms. That's what they want, 80%, which is a full operating room. So what I said is I modeled it out for them. I said, okay, here's what I'm going to do. I'm going to rent 2 operating rooms from you for the whole year. I'm going to give you 80% utilization at your best payer, which is Blue Cross Blue Shield, and I'm going to pay you that money. And let me rent the operating rooms and staff it myself and run the cases through myself and have anesthesia myself. And I'll go at risk.
You collect the money.
I collect the money. I just want the hospital tax ID number to get the rates.
Right.
And
that is that's a deal any business person do any day, right?
Let me take the risk. Let me see if I can run the efficiencies.
Give me my profit.
Yes.
And
that's America, right?
You make on it, I'm happy to do it.
That's right.
It's sort of like going to the Steinbrenners and saying, I'll tell you what, I'll rent you average 36,000 seats per game. I'll tell you what, I'll rent out 40,000 seats.
That's right.
Let me run the stadium.
That's right.
You get more, you have, whatever, 12% more, whatever the math is.
So the People's Republic of China, which is also the Rush, administration at the time, but not the same now, but they said no. And just to give you perspective, in 2000, I just looked at the numbers, 2012, I did 629 inpatient cases at Rush, 2012.
Wow, that's just huge.
10 years later, I did 27.
Yeah, and it's like a strike that they'll never make that money back, and they don't realize what they lost.
They realize now because they lost
They really-
millions and millions. But you're right. It took them a decade to figure it out.
To figure it out. And I'm writing an article right now on how to value surgeons. It's for a business review. How to really value surgeons, not value equal outcomes over cost, but what is the value? If you're the CEO, or a CEO of an ASC or CEO of it, how are you going to value your surgeons? And time is part of it. Cost is some part of it. Reputation is part of it. Volume, of course, in how much wood can a woodchuck chuck if a woodchuck only chucked wood, right? How many cases can you do in the same amount of time period that somebody else does cases? They could be booked, like you said. That's a great point. I think one of the great points you made tonight. Someone says they're booked out for 3 months, but they're doing 1/3 the number of cases you're doing, and you're booked out 2 weeks to 3 weeks.
The one challenge I had with the hospital, because they were taking away my block time, and I gave it away now, but I said, the block time metric is 7:30 to 3:30, how much you use it. So one of my partners uses all of it because he does one case, it takes that long.
Right.
And he's rewarded with extra block time. And I said, the metric you should be using is dollar per hour, RVU per hour,
Right.
and then the labor costs,
right,
for those. And
right.
they looked at me with blank stare, and then they realized it once again 10 years later, like that's probably the right metric to utilize.
Yeah, time-driven, activity-based costing on everything. And I joke around. I tell my COO I have an equation: gross revenue minus the checks you write due to surgeon behavior equals working capital for the hospital.
Yeah, bad surgeon behavior. That's rampant. You can't control it. That one.
No, but surgeon behavior meaning like I choose to use this implant.
Oh yeah,
Or I choose to be slow in the OR. I choose to be on my phone between cases and delay the case. Checks you write due to surgery.
I give a talk on how to transition to an ASC for a spine surgeon, and the number one characteristic is, or number one thing you have to do as a spine surgeon is introspection. Are you capable of doing that case? Are you capable of how you change your practice? Are you capable of modifying your technique? All these things. And if the answer is no, then it's okay. Just you can't fight the fight to go to the ASC then.
Yeah, that's a great final comment. So, Kern, I'm going to want to thank you for your commitment to the journal and for coming here tonight. And I want to thank everybody who has been here, and this will be recorded. I do want to say in the fall, we're going to go to Wednesday nights because of Thursday night football. So you know
your audience, know who you're capturing. I get it.
Yeah, I got it. This is orthopedics, man. But thank you so much.
Ira, thank you for having me. I appreciate it.
All right. We're going to sign off now, everybody. Okay. Bye-bye.
Thanks.